Hello, hope you guys are all doing well. We're going to talk a little bit about hypertensive disorders of pregnancy. Now, I would say that this is the most common medical complication you're going to see in pregnancy, so it is probably a very important topic. If you were still in clinical, or for those of you who had a few weeks of clinical, or maybe even 1 week, you probably already saw patients that were dealing with hypertensive disorders in pregnancy. It is one of the leading causes of maternal, fetal, and newborn morbidity, mortality, and it's actually increasing in prevalence. Being the most common medical complication reported during pregnancy, it actually affects 5 to 10% of all pregnancies, which is huge. Again, it contributes to maternal and infant morbidity and mortality worldwide. And if we think back to our very first week of lecture, we talked about the 3 most common reasons that killed women during labor or during pregnancy. And one of the 3 top reasons was hypertensive disorders. Now, when we talk about hypertensive disorders, you are coming in from med-surg and you already know people have a hypertension. And we know that it's becoming more prevalent in today's society, particularly with the younger people. So we have a lot of people coming into the pregnancy already with hypertension. And those people that come into the pregnancy with high blood pressure, it's basically chronic hypertension. And those that develop hypertension in pregnancy, we call it gestational hypertension. And gestational hypertension can actually progress to preeclampsia, and those with chronic hypertension can get preeclampsia. And then we can also have severe preeclampsia. The worst case scenario is when it turns to eclampsia, which actually is a seizure. And we'll talk a little bit about more of this classification as we move along. Now, if you look at this slide here, we're going to look at this line here as being 40 weeks. So chronic hypertension is those people that come into the pregnancy with high blood pressure. So anybody who comes into the pregnancy up to 20 weeks that develops high blood pressure will probably consider to be chronic. And that's because some people will come prenatal appointment and they'll have a little bit of high blood pressure. Well, they probably had some high blood pressure prior to pregnancy. So anything prior to 20 weeks is called chronic. Any high blood pressure that develops after 20 weeks is considered gestational diabetes. This is high blood pressure that basically is caused by the pregnancy. Now, gestational high blood pressure or hypertension is basically just a high blood pressure, which basically we say is basically elevated, but it will not include other problems like protein in the urine or some of the signs and symptoms of preeclampsia. But we know that anybody that comes into the pregnancy with high blood pressure or anybody that develops high blood pressure during the pregnancy is like a red flag. We're going to be looking out for preeclampsia, severe preeclampsia, or eclampsia immediately. So again, anybody with chronic hypertension or anybody who develops gestational hypertension is at high risk for developing preeclampsia during their pregnancy. And a lot of people wonder, well, why is that? Why are women at risk for gestational hypertension during their pregnancy? Why does this happen? And we're still trying to discover, and there's a lot of guesses and everything else, but what we do know is this, is that here we've got the uterus, and here we've got all the spiral arteries that are going to be supplying blood to the baby. And here we have the embryo. Fertilization occurs in the fallopian tubes. And around day 6 to 7 after fertilization in the fallopian tube, it drops into the uterus and attaches to the uterine wall right here. So it needs to attach. The interesting thing is this is a very important time because it needs to attach well enough into the uterus that it gets a good blood supply from all those arteries, the spiral arteries. But it doesn't want to attach too much because then we're going to have problems with the placenta actually coming out after delivery. So the attachment is really important. But remember this, if it doesn't attach good enough into the uterus, it's not going to get enough blood supply as that fetus grows later on in pregnancy. In addition, another thing needs to occur. These spiral arteries need to widen and increase so that there's an increased blood supply and oxygen to the fetus as the fetus grows. Now, what happens sometimes in pregnancy is either that embryo doesn't attach well enough or the spiral arteries don't widen enough during pregnancy, usually occurring about 20 weeks. And what happens is the fetus then is crying for more oxygen. And it becomes a systemic cry. And we may have already learned that when the body doesn't get enough oxygen, it becomes very angry. And I call these cells angry because when they don't get enough oxygen, they actually release inflammatory molecules in mom's blood. And these molecules actually damage the lining of the blood vessels throughout the entire body. And this damaging of the blood vessels, mainly the endothelial cells, is what leads to all the signs and symptoms of preeclampsia. Number one, if it's damaging the lining of the blood vessels will lose their ability to control, tone, and relax, which causes the high blood pressure. In addition, because of the endothelial cells, the cells become very leaky. And if you think back, to whether you learned in patho and whenever, is that when the cells actually become leaky, they leak protein. And we all know what follows protein. When the protein is released from the cells, water will follow the protein. And that leads to edema. And so if we look at the cells throughout the whole body are actually affected, the blood vessels can't relax, the blood pressure rises. And remember, the baby is dependent on mom's blood pressure. If mom's blood pressure gets high, sometimes there's a constriction of the blood vessels and baby won't get enough oxygen, which causes problems with the baby growing, intrauterine growth restriction. We also have the high blood pressure. Now think about the leaky cells, leaking protein. The water follows the protein out of the cells and you have edema. So basically, if you look at the lungs and you think about edema, you'll end up with pulmonary edema. Think about the blood vessels to the eyes. Okay, there's vasospasm, which causes problems with the retina, so people will see maybe spots, or their vision will become blurry. The blood vessels to the kidneys are also affected. You have vasospasm, which increases uric acid. You also have the blood vessels to the brain affected. Okay, you get cerebral edema, okay, which causes CNS irritability. And that's where mom will come up with a headache, hyperreflexes, and actually they can actually become turn into a seizure, a cortical brain spasm, or a seizure. Okay, so we have the whole CNS involved in this as well. So just to go back, we know that people come in with hypertension into the pregnancy, which is chronic. Gestational hypertension is defined as blood pressure that occurs after 20 weeks without protein in the urine and with a blood pressure greater than 140/90. And that's just a standard because it actually depends on what the blood pressure of the patient was coming in. But for most general purposes, we state 140/90. Preeclampsia is defined as hypertension, high blood pressure, and protein in the urine, which develop after 20 weeks of gestation. And it can be categorized as mild or severe. And I'll be sending out a handout too. So the more severe the amount of protein and the signs and symptoms and the lab results become, the more severe the preeclampsia is. And then eclampsia is actually the onset of seizure activity or coma in a woman with preeclampsia. Seizures can occur before, during, or after birth. And we already learned that 1/3 of eclamptic surgeries occur after birth within the first 48 hours of birth, after birth. So we're always thinking we don't want to get to this. So really what we're really going to be in tune with is catching it early. The thing is that we already talked about how preeclampsia is a condition that can only happen with pregnant women. So the way to cure it is, if you're not pregnant, you can't have preeclampsia. So before it gets severe, and if the baby is well matured enough, there is always the benefits versus the risks. But if it's starting to get severe, they will deliver the baby, even if it's a little premature, because once the baby is out, the preeclampsia will resolve itself within a couple of days. Chronic hypertension is basically present before pregnancy or before 20 weeks gestation. We know those people with chronic hypertension, we're going to be watching them like a hawk because they're very likely to get superimposed preeclampsia, just meaning their high blood pressure will actually become preeclampsia. So chronic hypertension with superimposed preeclampsia is just basically women with chronic hypertension that develop protein in the urine and other signs and symptoms of preeclampsia. Again, the etiology is unique to human pregnancy. We know only if you're pregnant you can get preeclampsia. The cause is basically unknown, but theorists try to explain the etiology. And we talked a little bit about this already, how there's disruptions in the placental perfusion and endothelial cell dysfunction. Basically, an abnormal development of blood vessels in the placenta, okay? Or the spiral arteries do not widen to handle the need for increased blood flow, or a bad job of the trophoplasts digging into the placenta. But basically, this all results in the placenta not getting enough oxygen for the fetus. Again, if the cells of the placenta aren't getting enough oxygen, there's the release of the inflammatory molecules that are toxic to the endothelial cells. Endothelial cell dysfunction is caused by placental ischemia. And this anomaly actually causes generalized vasospasm, which leads to the signs and symptoms of preeclampsia, which we already talked a little bit about. There's poor tissue perfusion in all the organ systems. There's increased peripheral resistance and blood pressure. There's an increased permeability and capillary leakage. The vessels lose their ability to control, tone, and relax, so which results in an increased blood pressure. The increased permeability and capillary leakage actually will lead to the kidneys leaking protein, therefore you get protein in the urine, and also kidney vasospasms, which increase the serum uric acid. Other blood vessels leak into the tissue. Remember, water follows the protein, which results in edema. And dysfunction of vessels in the brain. You get cerebral edema and cortical brain spasm, which causes CNS irritability. And the signs and symptoms we see is headache, hyperreflexes, and seizures. There's liver dysfunction as well when it doesn't get enough oxygen. We get elevated liver enzymes, which are the AST, ALT, epigastric pain, and nausea and vomiting. The lungs can have pulmonary edema, and of course the eyes experience vasospasm, which is a decreased blood flow to the retina, which causes visual disturbances. The results on the fetus could be that basically there's not enough oxygen and nutrients. So there's IUGR, intrauterine growth restriction. The baby will be small and not developing, right? Decreased amniotic fluid, a low birth rate, preterm birth, and abnormal fetal oxygenation. And we'll see that abnormal fetal oxygenation sometimes on the strips, slates, variability as it really progresses into more severe cases. So again, when we talk about the patho, we should be able to identify the signs and symptoms of headache, visual changes, epigastric pain, swelling, reflexes, protein in urine, elevated liver enzymes, and low platelets, and thrombocytopenia. And if you think about it, if you just think about the patho and what's happening with the whole body, these will make more sense. So it's really important that we get the correct blood pressure, okay? Because we're really trying to detect if there is a blood pressure that's greater than 140 or 90. We want to keep the patient in a quiet environment with a call light in reach. And remember, anybody with preeclampsia is a seizure precaution because eclampsia can occur at any time. And we've already learned probably sometime in nursing school that if a patient is having a seizure, your most important nursing intervention would be to stay with the patient and make sure they stay safe during that seizure. Our assessments would be including looking for edema, dependent, pitting edema. We would also be checking reflexes and clonus and assessing lab values. To control the blood pressure, we need, if the blood pressure gets really high, we need to bring down the blood pressure. If we don't bring down the blood pressure, what will happen? Same thing as anybody with high blood pressure, okay? So to control the blood pressure so that they don't stroke out, we can give hydralazine, labetalol, Eldamet, nifedipine, and other blood pressure medications that you've learned about to decrease blood pressure. Remember, if you don't decrease the blood pressure, you're going to have a crisis on your hand, same as you would with somebody else without a controlled blood pressure in a med-surg unit. They could stroke out. In addition to controlling the blood pressure, we want to prevent seizure activity. And the drug of choice for this would be magnesium sulfate. Remember, we talked about magnesium before. It's a calcium channel blocker, and if the muscles don't get calcium, they don't contract, it actually will decrease the patient getting seizures. So we need to give it through the IV. So we have an IV. Usually the main line is going to be lactated ringers, and this would be piggybacked via infusion pump. The loading dose would be 4 to 6 grams, and then we usually would have a maintenance dose anywhere between 2 and 4 grams. It is a high alert medication, meaning if you give too much of it, it could cause a problem. Now, what could happen if you give too much of magnesium sulfate? Well, think about it. It's decreasing your activity. People on magnesium sulfate will report feelings like they feel like a bus hit them, like they've got the flu really bad. They have no energy. It really limits their reflexes, their movement is sluggish. And the reason it's a high alert medication, because if you give too much, it relaxes the patient too much, and they could actually get respirations really, really low, below 12, and then stop breathing. So assessments on anybody receiving magnesium sulfate are really important to check their reflexes, to make sure they have reflexes, and to make sure they're not losing their level of consciousness. I once had a patient that had been sleeping all night and was doing fine, and I was reported from the nurse in the night shift that she had a great night. She slept really well. When I went into the room to assess her, she couldn't even open her eyes. Why? Because the magnesium was so high. What was my first nursing action? Turn off the magnesium sulfate, notify the healthcare professional, and sometimes we have an antidote to give it, calcium gluconate. Although that patient didn't need it, a lot of times they just needed it shut off. But if we keep a close eye on them, we can tell the magnesium level is too high and we can decrease it. Again, many people will ask in preeclampsia if they've had it during pregnancy, will it go away? In most cases, yes, it will resolve. But sometimes these patients are more likely to have cardiovascular disease later in life. They're more likely to develop chronic hypertension. It may take, the worse it is, the preeclampsia is during the pregnancy, it may take a little bit longer to normalize blood pressure after the delivery. It remains an intriguing disease unique to pregnancy, and the precise treatment and etiology is yet to be determined. What we also know is that anybody with preeclampsia, we have to watch them very, very closely for their labs. We watch for trends. If the protein in the urine is high, and if the AST, the liver enzymes, are climbing and the platelets lower, they are very prone for HELLP syndrome. And this is just a laboratory diagnosis for a variant of severe preeclampsia that involves hepatic dysfunction. And it's characterized by hemolysis, elevated liver enzymes, and low platelets. It occurs in 1 in 1,000 women, but the mortality rate can be as high as 24%. The etiology is unknown, and it is seen in older Caucasian multiparous women. It's a laboratory diagnosis, not a clinical diagnosis, but a lot of these people end up very, very sick and in the ICU. Again, questions, go ahead and write them down. And when we have class on Wednesday, you can ask any questions, and I'll probably have a little activity on class day regarding hypertensive disorders. Thank you and have a wonderful day.